My name is Kinga Kovács, and currently I'm a pediatric resident at the Department of Obstetrics and Gynecology at the Neonatal Intensive Care Unit. Our vision is that the focus in neonatal care should be on eliminating as many complications of prematurity as possible. That's why our mission is to investigate perinatal risk factors. To achieve these aims, here are our specific goals. The first two is related to the histopathology of the placenta and the umbilical cord, and the third one is related to the apnea of prematurity. Our first project is a meta-analysis investigating the prognostic role of fetal inflammatory response. First, I would like to give some explanation to these terms. Chorioamnionitis means the inflammation of the chorioamnionic membranes. And since it's the maternal part of the placenta, this is part of the maternal inflammatory response. And as this inflammation progresses to the fetal direction, it reaches the fetus, causes fetal inflammatory response, and as a part of it, chorionic vasculitis and phoenicitis. Intrauterine inflammation is one of the leading causes of preterm deliveries, and several studies has already showed association between chorioamnionitis and different adverse outcomes of prematurity. However, the impact of fetal inflammatory response in this equation is unclear. That's why our aim was to investigate the role of additional fetal inflammatory response with chorioamnionitis. Our population contained preterm neonates or very low birth weight neonates, and in the exposure group we included neonates with chorioamnionitis and fetal inflammatory response. Meanwhile, in the comparison group we included neonates with chorioamnionitis alone. In the end of the selection process, we had 47 eligible articles, amongst which we have 23 that use more strict, more homogeneous histological classification. So we had random analysis both on the smaller group of articles and both on the whole pool as well. These are the list of our outcome, and these are the major morbidity of prematurity. One of our primary outcome is mortality. And as you can see, we conducted subgroup analysis using the mean gestational ages of the studies, and we used the cutoff line of 28 weeks of gestation. And regarding mortality, according to the 16th study, we found no significant difference between the two populations. We found similar results in case of early and late onset sepsis as well. In case of bronchopulmonary dysplasia, which is one of the most common chronic respiratory morbidity of prematurity, we found no significant difference in case of analyzing the whole pool of articles, but here analyzing the smaller group of articles with more homogeneous histological classification, we found its odds to be elevated among neonates with fetal inflammatory response in the subgroup with lower gestational ages. In case of intraventricular hemorrhage, we found it to be associated with the presence of fetal inflammatory response. However, this association could not be demonstrated in case of severe intraventricular hemorrhage. We analyzed one maternal outcome as well, clinical chorioamnionitis. This means clinical symptoms prenatally, and here we found it to be threefold elevated among infant mother diets with chorioamnionitis and fetal inflammatory response. All in all, the strength of our study that we only included articles strictly based on histological evaluation, and we have this homogeneous histological classification group. But just as important are limitations that in certain articles the outcomes are based on slightly different criteria, and these outcomes are multifactorial and highly influenced by different confounding factors such as gestational age or mortality. In conclusion, we can say that after analyzing several outcomes, we found association in case of intraventricular hemorrhage, and among extremely preterm neonates in case of bronchopulmonary dysplasia. And according to our results, chorioamnionitis with fetal inflammatory response is clinically much more apparent than chorioamnionitis alone. Our implication for practice is that regular histological examination of the umbilical cord should be part of the prognosis evaluation, and in case of clinical chorioamnionitis, a more progressed intrauterine inflammation should be suspected, and our implication for research is that it would be important to identify the possible pathways of the progression of intrauterine inflammation and its role as an independent risk factor. And we submitted our manuscript to American Journal of Obstetrics and Gynecology, but unfortunately it recently been rejected. Our second project is a Cohort Analysis investigating the intrauterine route of inflammation. As I mentioned, the fetal component of inflammation usually follows the maternal component. However, the pattern of neutrophil margination within the umbilical cord is unclear. That's why our aim was to investigate these topographic distribution in our cohort. So we collected the histopathological data of preterm neonate that had full histopathological evaluation. That means evaluation of the placenta and 2 sections from the umbilical cord. 1 section really close to the placenta, usually contained by the placenta specimen, and 1 section really close to the fetus, usually 3 to 4 centimeters from the neonate. And here are the categories that we found. No inflammation only in the placenta, inflammation in the placenta and the placental end of the umbilical cord, and the 4th one is when we could see inflammation at all sides. And here is the distribution that we have found. And further analyzing this distribution regarding the stages of chorioamnionitis, we found that the rate of stage 3, so the most severe cases of chorioamnionitis, were more frequent in case of infant mother diets where both ends of the umbilical cord showed signs of inflammation. Here I have to mention that we had these 2 additional cases, those who could not fit in any of these categories. In conclusion, we can say that the presence of the inflammation in the fetal end is highly associated with more severe chorioamnionitis, and that suggests gradual progression, and 1 section from the placental end could provide sufficient information about the presence of fear. And in the future, we are planning to investigate the short-term neonatal outcome in association with the location of fear, fetal inflammatory response. Our 3rd project is a randomized clinical trial investigating the effect of additional pre-extubational loading dose of caffeine citrate. One of the most common indications of reintubation or intubation are frequent episodes of apneas. And since the CAP trial, which is a caffeine for apnea of prematurity trial, there is an evidence that caffeine administration reduces continued apnea and associated with shortened duration of ventilation. And since this trial, caffeine is one of the most commonly administered drugs at neonatal intensive care units. Nevertheless, its application is quite variable. And such a variability we have seen in our institution between the 2 neonatal intensive care units. Pre-extubational loading dose of caffeine citrate, so 20 milligram per kilogram of caffeine citrate, was part of the extubational protocol at one of our neonatal intensive care unit. Meanwhile, on the other, it was not. So we collected the data of these mechanically ventilated preterm neonates and compared the extubation success rate. And we found that the extubation failure, so the reintubation within the next 48 hours, was significantly lower among neonates that had received pre-extubational caffeine citrate. And seeing these results, to gain more evidence, we planned this clinical trial in which our clinical question is, does additional loading dose of caffeine citrate 1 hour before planned extubation reduces extubation failure? Our population will be preterm neonates that had been mechanically ventilated for at least 48 hours. And in the intervention arm, they will receive an additional 20 milligram per kilogram loading dose of caffeine citrate before extubation. And their primary outcome is reintubation within the next 48 hours. And we think that this study can contribute to finding the optimal dosing regimes regarding caffeine. Here are our eligibility criteria, inclusion and exclusion criteria. And beside our primary outcome, we have secondary outcomes as well, like frequency of apneas, heart rate, gastric residuals, or blood pressure. And we managed to obtain the ethical approval, and we are doing the international registration and the IT development currently. Here is a quick overview of my 3 projects and my additional activities from the last year. I attended 4 conferences, and I have a TDK student who also attended 1 conference. And thank you for your attention. I brought a quote for the tiny one from Tiny Spark May Burst a Mighty Flame.
Congratulations. Just a question about the first study on the chorioamnionitis. You mentioned there was a connection with intramatricular hemorrhage. Can you explain that? Is etiological?
Yeah, we have theories about it, and in the literature it has several theories, because this germinal matrix really has really fragile vessels, and these are really sensitive for hemodynamic disturbances, and these cytokines, which are really in a high concentration in intrauterine inflammation, can cause directly a vasodilation or indirectly effect of an endothel.
I have two questions. The first question is that in your first project we see a lot of p-value in case, for example, for the heterogeneity. What is the meaning, the p-value in that case?
Yeah, here, the p-value?
Yes, for the heterogeneity.
Yeah, it's we can measure the heterogeneity with I-squared test, and the higher the I-squared test, the higher the heterogeneity, but it's reversed with p-value. It's the lower the p-value, the lower the heterogeneity.
What is the null hypothesis?
The lower the p-value, the higher the heterogeneity. What is
the null hypothesis for the...
that the two population is homogeneous.
Yes, and my second question is about for both projects. So here you made some calculations. So you get your data based on histological sampling. And is it important who did the samplings, a pathologist, or we're doing that, or with techniques, with a needle size?
Yes, that's important. That's why we made these two groups of articles. Mostly the person, if it's a fetal pathologist, then it's must be a quality evaluation. But the description of the pathological report was different between the two groups of articles. One only mentioned there were fetal inflammatory response or there were phonicity, and no mentioning about where were these neutrophils, or they included the chorionic vasculitis in the definition of fetal inflammatory response. So we could not handle these articles as the same. So that's why we had random analysis both as a super selected group as well.
My question is regarding your randomized control trial. Do you plan to measure the concentration of the caffeine, or is it important? What do you think about this?
Yes, thank you for your question. It's a really good one. We've been contemplating about it. But according to current studies and the current NICE guideline, with those one-timely higher dose, it's not necessary to measure the level of caffeine. However, of course, it would elevate the quality of the trial. But one timely measurement would give us not enough information about the level of caffeine, and multiple truing blood would be a significant blood loss for this population. So we decided not to do. There are studies measuring caffeine level from saliva and urine, but they are not standardized and they are not routinely applied.
Thank you for your presentation. I have two questions actually regarding your trial. The first one, why did you choose the 48 hours for an outcome? And the second one is regarding your preliminary data. As I have spotted, there was a significant difference in the complete steroid prophylaxis between the two types of caffeine administration. Would you consider it as a confounding factor, and would you use stratification on it in your trial?
Thank you for your question. Regarding your first question, we chose the 48 hours because around 70 or 80% of the reintubation happens because of the respiratory reasons. So what we are looking for here, in the next 48 hours. And it's not just literature, that it's also that we have found in our population. And regarding for your second question, yes, you spotted it. There were a difference regarding completed antenatal steroid prophylaxis, and we are planning to stratificate our randomization, not just antenatal steroid prophylaxis, also for gestational age.
Okay, I have a very different type of question, because I mean, you submitted your first work and then you got a rejection, which happens actually to all of us, I think, including committee members. So what is next? What's the strategic plan with those?
To tell the truth, we received a huge review, like 4 reviewers telling like really useful stuff. So we are planning to involve those suggestions into our article that were really useful, and we made an inquiry to the journal. If we submit it again, what would they say? And they told me they encourage it, but they could not also, of course, say that it will be published. So they will send it a review again.
I congratulate you. It would be just a technical question. I saw that the sample size calculation is 222 or something.
26, yeah.
So what do you guess, how long will it take to do the RCT in 2 centers?
I think it's about 4 years. Like we have a lot of exclusion criteria, and this extubation has to be a planned extubation, and in this population there are several unplanned extubation.
Yes, sure. And just another technical question, are you planning to publish those results? Because when you started your presentation about the RCT, I thought that it's an extra project, small but really nice, with nice
thank you. We are thinking about a short letter, maybe, but the main project is the protocol for a randomized trial.
I congratulate you.
Thank you.
Congratulations on your work. And my question is regarding to your second project, where you analyzed and categorized the preterm infants. And as I remember, there were 2 unique cases which you couldn't categorize. Do you know the reason behind this, or have you got some explanation for this?
Thank you for your question. To tell the truth, we watched the clinical data of these 2 neonates again, and we saw no extraordinary data or that would be specified for them. One of them had isolated phonicities. That means there were no inflammation in the placenta, and inflammation only in the umbilical cord, which is quite rare entity. It, according to the literature, is like less than 3 to 5% in cases when there is a phonicities, and it's associated with meconiums in the amniotic fluid, but we found no meconium staining, no reports about it, any of these cases.
Sorry, I have one comment regarding to the table in your second study, that it sometimes contains dots and sometimes contains commas for decimal separator, and it could be dangerous.
Sorry. Thank you.